So open fracture is a fracture in which the fracture or fracture hematoma communicates with the external environment. As you can see, there is a multiple fracture of the bone. This is a crush injury, extensive damage to the soft tissue, and there is possible damage to the neurovascular structure, artery, nerve and vein. So today the learning object is introduction to the open fracture, its clinical features, management, its assessment, classification, and as you know, the skin prevents deeper tissue from infection, so prevention of infection and wound management. And fracture stabilization and management of the established infection. So, as I told you, the open fracture is a fracture in which the fracture or fracture hematoma communicates with the external environment. It may be a puncture wound which may be just visible and with the continuous bleeding, or it may be a huge wound with extensive exposure of the soft tissues, as we had seen in the picture. So, how the fracture heals? The fracture heals from the hematoma that is formed at the fracture site. The stage of hematoma, then soft callus, then hard callus, then consolidation. So if we lose the hematoma, the fracture healing is impaired and delayed union is likely. So assessment and classification of open fracture. As you know, fracture is a traumatic injury, and do you know ATLS, Advanced Trauma Life Support? So if patient has systemic involvement, then it is managed as per ATLS guidelines: airway, breathing, circulation, then disabilities. So the patient is evaluated and managed according to ATLS protocol. Then injured extremity is assessed for neurovascular injuries. Distal movements, finger or toe movements, then sensation in the areas of nerves. Do you know autonomous zones, which are regularly supplied by the same nerve? So then, as high grade trauma may injure deeper tissues, especially muscles, and muscle edema causes compartment syndrome, which leads to impairment of the circulation. And photographic documentation of most of the patient's condition is necessary so that future legal procedure can be easily tackled. If immediate operative treatment is not possible, as patient may have polytrauma involving more than 2-3 systems, then we must irrigate the wound. We wash the wound with the saline so that all the debris and foreign tissue is removed. Then wound is dressed and splintage is given. If we do not stabilize the fracture, continuous movements occur, so hematoma get disrupted, so continuous blood loss, then the movement of the fracture causes pain, so it may increase shock, and the sharp ends of the bone may injure uninjured tissue, so there may be vital organs like artery, vein may get injured, and further the movement at the fracture site causes ARDS or fat embolism. So as far as classification of open fracture is concerned, there is a Gustillo-Anderson classification in which class 1 is when wound is less than 1 centimeter, minimal contamination and minimal soft tissue damage. Then stage 2 when more than 1 centimeter but less than 10 centimeter. Then moderate soft tissue damage. The bone is adequately covered with the soft tissue or periosteum. And stage 3A when the wound is more than 10 centimeter long, extensive soft tissue damage, and adequate bone coverage is still there, periosteum is covered. 3B is the stripping of the periosteum. As you know, periosteum gives blood supply to the cortex, and split skin graft may be taken on the periosteum. So after periosteum is lost, split thickness graft is no longer possible, and we have to give muscular or a cutaneous flap. And for open fracture of the tibia, we use Ganga hospital score. And disadvantage of Gustillo-Anderson classification, it has undergone many modifications as it was found inadequate. So there is a wide spectrum of injuries that occur in 3B, but it does not differentiate them, and mainly depends on the size of skin wound. Do not address the limb salvage. What is limb salvage? So as we have seen the photograph in the start, so if we can save the limb, that is called limb salvage. So it may involve bone transport, neurovascular repair or graft, and here poor inter-observer reliability. So Ganga hospital score for open injuries, it accounts for skin and fascia, musculotendinous and nerve units, then skeletal structure, bone and joints, and comorbidities. So, what is primary aim in the treatment of open fracture? Prevention of infection. If infection occurs in the bone, it may not get eradicated, and it goes on in the forms of remission and recurrence. So all open fracture should be considered contaminated. Either bone comes out of the skin, or some hard object goes inside the skin to the bone. So this dirt and other tissues get inside the wound. So it is enhanced by the following: bacterial contamination, then colonization inside the wound, and if dead space remains inside the wound, that leads to accumulation of body fluids, and body fluids are very good culture medium, and it enhances the chances of infection. And if any foreign material occurs, it will lead to foreign body reaction. Inflammatory cells goes there, and pus formation may occur. So antibodies which are given, first generation cephalosporin, as most common pathogen is Staph aureus. So it is well covered with the first generation cephalosporin. And type 3, where there is a extensive soft tissue loss, we add aminoglycoside. And as you know, tetanus prophylaxis is given to all patients with the penetrating injuries. It is an anaerobic infection. So TT is given 0.5 ml regardless of age. And in patient where there is a not history of previous tetanus immunization is not known, and wound is likely to be contaminated, we give tetanus immunoglobulins. Then wound management. So we surgically clean the wound from dead tissue and foreign tissue. So the skin margin, as you can see in the photograph, that are freshened up. The minimum amount of skin is excised till we get the bleeding edge. As far as fat is concerned, fat is removed generously, and fascia and muscles are, if viable, then they are preserved, otherwise excised. So we irrigate the wound with a copious amount of saline. Then we remove the skin till bleeding edge is visible. Subcutaneous tissue, including all contaminated discolored tissue, and muscle. How can we differentiate between viable muscle and dead muscle? The dead muscle looks darker, and it does not have tone, and it does not contract on the pinching. So all dead muscle is removed. Tendon, if cut, we debride the small parts and then we can suture it back. And fracture treatment we will discuss later. So if there is a small fragments of bone which devoids of soft tissue attachment, that means the blood supply to that piece is not present. So blood gives nutrition to the bone and energy, and it prevents infection as the inflammatory cells comes to that particular part. Then fracture stabilization. For type 1 fracture, any technique can be taken up. If a small puncture wound is present and clean, or it is inside out, that means the wound is caused by the external movement of the bone. The sharp end of the bone has pierced through the skin. So here we can treat it as a closed fracture also, and we can put plate or nail. And other severe injuries we usually temporarily fix with the external fixator, and the fracture treatment usually depends on the bone that is involved. How much soft tissue is attached to the bone. The attachment of the soft tissue gives blood supply to the bone. So healing power, how much is the healing power? Then the bones of lower limb, we need a special fixation so that we can mobilize the patient early. If we immobilize the patient for a long time, so what are the disadvantages? So we start with the loss of earning, then other family members' earning can also be compromised as the bedridden patient needs attendant, and then if the patient is elderly, he may get dependent pleural effusion, and in the prolonged bed rest, the muscle wasting occurs and osteoporosis occurs. So it is ideal that we mobilize the patient as soon as possible. So options available in the external fixation, you may have seen tubular fixation and the ward. Here the metal tubes are fixed with the change screw going through the small incision in the skin. So it allows, external fixator allows frequent dressing as open wound needs regular dressing, and it allows plastic surgeon to give flaps, and we can frequently observe the condition of the limb. And in the left, that is a small wires is passed through the bone, and it is called jazz fixator. And in this picture you can see ring fixator. So when there is a piece of bone that is lost at the site of injury, or it is lost in the time of debridement, which is dead bone, so we apply a laser of fixator, in which in the upper part you can see a corticotomy is done, and that a new formed bone is stretched, so length is regained. Here you can see the wound is getting red. When wound gets this type of image, and that is free of infection and vascular, we can put skin SSG, skin split thickness graft, and usually external fixator, except that ring fixator, Alizarov or railroad fixator, we use them temporarily till the fracture is fit for internal fixation. So it maintains reduction and keeps the soft tissue in the anatomical position, and gives the plastic surgeon a space to work on. Pin track infection is most frequent complication with the external fixation, and metaphysio diaphyseal fractures are usually treated by external fixation. Intra-articular or epiphyseal injuries are usually not fixed with the external fixator. So primary internal fixation, as we have discussed, when wound is clean and very small, the plate fixation needs increased soft tissue exposure and periosteal stripping, so it may lead to infection and usually avoided in the open fracture. And if primary fracture stabilization is done, then intramedullary nails are of choice, and in that too we do unreamed nail. As you know, intramedullary nail goes inside the medullary cavity. So to accommodate the largest diameter of the nail, we ream the medullary cavity. So the reaming causes devascularization of endosteum, as inner 2/3 of the bone is supplied by the endosteal vessels, so that is lost, and the reaming is done in increasing order, 5 mm, 0.5 mm increasing order, so operating time is more. And as you know, the fat medullary cavity contains fat and red marrow, so that may go into the blood circulation by the pressure exerted by the reamer. So fat embolism and ARDS and thermal necrosis of the bone may occur. So disadvantage of unreamed nail is that we have to satisfy ourselves with the smaller diameter of the nail. So a smaller diameter may get fractured or implant failure, and the smaller diameter may allow some movement of the bone, so fracture reduction may not be perfect, and post stabilization may not be adequate, so it leads to a higher rate of non-union and malunion. Wound closure. Usually, if wound is contaminated, it is not closed. Only a small clean wound can be closed, or otherwise when at the time of debridement we usually extend the wound by surgically by incision, so that part can be closed. So the reconstructive ladder, if possible, best is primary closure. If primary closure is not possible, we continue to do dressing, and when we found there is no necrosis or infection present, we can go for secondary closure. Then we can do purse string suturing, in which the purse string is tightened every day, and so the wound gap is get smaller. And as we have discussed, we can go for skin grafts. Then we can do local tissue transfer. We can give cutaneous flap or musculocutaneous flap or free flap. Here you can see gastrocnemius rotation flap, and in middle third we can do soleus flap, and in the lower third it is devoid of muscle bellies, so free flap is needed in distal third of the tibia. Skin grafting, as we have discussed, when the area which receives the skin graft is free of infection and granulation tissue is healthy and vascularization is adequate. Flap coverage, when split thickness graft is not possible, then we have newer modalities like WAC therapy, in which negative pressure wound therapy. As we have discussed, the collection of body fluids inside any body cavity leads to the infection. So negative pressure dressing that evacuates that all the body fluids that are lying inside the wound, and it may obliterate the dead space, and it further enhances the vascularity of the tissues, as the back pressure of the fluids are removed and negative pressure is there. So healing is promoted, and bacterial pus, if that is being forming, is removed by the negative pressure. So bacterial burden becomes less, and as you know, the protein electrolyte that are result of the bacterial destruction are also removed. Then rehabilitation is very important, as soft tissue is involved in the injury, so muscle strengthening and muscle training is needed. So assessment and classification of open fracture should be done at the emergency department, and at the time of surgical treatment in the OT. And so you all may be knowing Glasgow Coma score. See, it involves the state of the CNS. Best eye response, best verbal response, best motor response. So a score of 13 or more correlates with the mild brain injury, 9 to 12 is moderate injury, 8 or less is severe injury. Then coming to the crush injuries, there is a mangled extremity severity score. It is described by Johnson et al. In 1990. Its component includes skeletal or soft tissue injury, limb ischemia, shock, and age. So MESS score of greater than 7 had 100% predictable value for amputation. So when distal part is non-viable and non-repairable, we have to still go for amputation. So for that we have two scores that is commonly used: Mangled Extremity Severity Score and Ganga Hospital score. Here the skeletal and soft tissue injury that may be low energy, like stab wound, simple fracture, or pistol gunshot wound. Then high energy, high velocity, and limb ischemia, pulse is reduced or absent, but perfusion is normal. How perfusion in distal part is evaluated? We can put pressure on the nail and it get blanched. So in how many seconds it re-get its color, and other is we can see the pinkish color of the fingers, or it may become pale or darkened if perfusion is decreased. So we can prick the skin with the needle and bleeding may come. So if pulse is absent, but if these signs are present, the skin is pink, warm, and there is a bleeding on pinprick, then shock should be managed before we test for the perfusion of the distal part. So age, if less than 30 or more than 50. So if we get injury like these, we have to evaluate it thoroughly beforehand, before giving treatment, so that later litigation is minimized. Ganga Hospital Open Injury Severity Score. It gives